here. So a few things, disclosures to start always. I now have a Chiari Clinical Research Center set up at Hopkins, which was funded by donations. I've done some consulting for Integra, which is unrelated to Chiari. And then I think, Chiari, as alluded to, there's a significant surgeon bias and personal bias when we talk about things. And so really the things I talk about, it is my opinion. I appreciated the quote from Daniel Patrick Moynihan. Hopefully my opinions are based on facts. And it will be slightly repetitive, both from things I say and also some of the things that Cormac said already. As he said, it is a talk based on questions. One of my patients runs a website and put it out there and then sent me a list of questions. I would say that it was in the hundreds, so I couldn't really answer all of them. And so I picked some and put it into a framework of what I thought would make a useful talk. If you asked a question and I didn't answer it, I'm sorry, and you can add it to the chat or something. And a few basic things like I think that are important to go over, because every once in a while we'll get a question of, okay, is my Chiari 1 going to become a Chiari 2? And I think it's important to note that these are different diagnoses. They're not a severity scale. You can have a mild Chiari 1, a severe Chiari 1, but it's always a Chiari 1. And then, so the original ones were 1 through 4, and then I think people have come up with 0 and 1.5. And so Chiari 1, really we're talking about the cerebellar tonsils herniating, and as was alluded to earlier, it's not really an ideal definition, but I think some of the other things that we see with it is that the brainstem is not herniated and the rest of the brain is typically normal. It's uncommon to have hydrocephalus, although we will talk about hydrocephalus as an etiology for Chiari, but it's not that as common that Chiari caused it with Chiari 1, and then Syringomyelia you can't have. Chiari 2 tends to be with myelomeningocele, and there typically are other brain anomalies. It's the cerebellar vermis that's typically herniating, and the brainstem and fourth ventricle can also come through the foramen magnum, and both hydrocephalus and Syringomyelia are very common. 3 and 4 put on the same slide because they're much less common. 4 you can have a citation for, which means I haven't actually seen one in my own practice. But a 3 is really an encephalocele, and so you know it if you have it from birth. And Chiari 4 is actually hypoplasia or aplasia of the cerebellum. Now what about these other things, Chiari 0, Chiari 1.5? The paper out of Alabama that talked about Chiari 0 was really that there wasn't significant hindbrain herniation, but there was a Syrinx. And the thought is that there's probably what's called neuracnoid web, or something that blocks flow out of the fourth ventricle. And the most important thing, and this is a question, I've heard people say this, that I have a Chiari 0 because I have Chiari symptoms, but I don't have a Chiari. And that's not Chiari 0. Chiari 0, you have to have a Syrinx. In terms of at least how it was defined. And then Chiari 1.5 was really people looking at something, that looks worse than a Chiari 1, but it's not a Chiari 2. And that's typically the tonsils are down, and also kind of the brainstem or fourth ventricle obex can be lower, but it's not a Chiari 2, and there's not an associated neural 2Z factors. Obviously, this talk, we're going to focus primarily on Chiari 1. And again, it's really the cerebellar tonsils going down through the foramen magnum into the cervical canal. I thank my partner Al Cohen for the self-portrait here that he gave me, but it's really a discrepancy between the container and the contents. It's an anatomical problem. My patients typically like to say is that their brain is too big, but effectively the space and the brain, there's a disproportion, and that leads to it. And so I effectively put all the questions in black, and then all of my slides are the text is blue. Is there a single source of information available for those treating or for patients suffering from Chiari? And the short answer is no. And I think it's one of those things that every practitioner and every patient is different. And there's going to be bias both from a practitioner and a patient standpoint, and everything's going to be different based on different experiences. So somebody who's been through it before may be a great reference, but their case may not be exactly the same as yours. And maybe, somebody else has seen something more similar. And so there's going to be a lot of things out there because it is more of a continuum. I think references, individual papers can be helpful, but many of them contradict each other. And I think both Cormac and I were part of the guidelines where that's really great is that it's a literature review that really pulls a lot of things together and attempting to synthesize all the data out there. But the problem is, for a lot of things, there's not great data. And so you can't make definitive statements because the evidence isn't good enough to do that. So I think it really is something where you just have to try to keep learning and doing more as you go. A lot of basic questions. Can you show the proper alignment line? What's the difference between Chiari and cerebellar ectopia? What about 3 versus 5 millimeters? Why would it show up and then not be there a few years later? And so I think if we look at the picture here, I've tried to draw that line there. Effectively, that line is from the clivus to the skull base at the back there. And the idea is you're trying to duplicate the foramen magnum so you can measure how far below it is. So that's the line. But the problem with it is that it can, on an MRI, it can sometimes be hard to tell exactly where are you drawing it, which point are you picking, and is there tonsil going lower on one side than the other, things like that. And I quote Dorothy, who's there, Eric, what is Chiari? And Cormac alluded to this already. We have that 5 millimeters out there, but that's not necessarily a great definition because we have patients who are asymptomatic with more than 5 millimeters, and I have some patients who are symptomatic with less. And so people are going to choose what they're going to choose, whether it's 5 millimeters or 3 millimeters. And to answer the question about how do you define ectopia, for the most part, ectopia just defines the tissue that's not where it's supposed to be. So if someone's using a 5 millimeter definition and you have 3 millimeters, they may say that that's cerebellar ectopia. But that's really, I think the terminology that doesn't matter as much as it's a little bit of semantics. And similar to kind of what Cormac alluded to is my personal bias is to, and sorry for the typo, treat more based on the appearance. Are the tonsil rounded or pointed? What's the relation to C1? Typically, the canal space narrows a lot in C1. So if the tonsils are going below C1, there's probably going to be less space and they're going to be more compressed. What does the fourth ventricular outflow look like? What does the foramen magnum look like? Is it really full? Even if the tonsil is only down 2, I had a patient that the tonsil didn't go up a lot, but had a big syrinx because the outflow was blocked because everything very full right at the foramen magnum. And then is there compression or deformation? Does C1 or the skull base, effectively look like it's digging into the cerebellum or things like that? And so those are the types of things I'm looking at to say, is more space or is the lack of space the problem for this patient? And so other questions that come up, patients will come in and say, in the report, it says my Chiari went from a 6 to an 8. I'm really worried that it's worse. And I think a lot of this is inconsistency in measurement. And, it can be interrelated reliability, like different radiologists. And, you could do the study where you gave the same scan to 10 people to look at. And how much would you get the same number? I also wonder if you gave the same person the same scan like months apart, how much would you actually get the exact same number? So I think when you're comparing things over time, it's really important to just look at them next to each other and say, do they look the same or different, versus looking at one measurement in a report versus another measurement in a report. So that's why when people see me with things like that, I always just ask them for their old films so we can actually look at them. One other thing that comes up, and there was a question about that we can see there, is upright MRIs. And, can you see something on an upright MRI that you don't see on a supine MRI? And I think it makes sense with gravity that things should be down. But honestly, when I've had patients who didn't have a Chiari on, or what I didn't think was a Chiari on supine MRI, and they wanted to get an upright MRI and they got one, it didn't really look much different. Or patients who did have Chiaris, and it didn't really look that much different to me. So personally in my practice, I don't think that they moved the needle that much that I would change what I'm saying based on an upright versus supine. But obviously, every case is different, but I haven't really seen that in my practice. This is, again, as Cormac kind of gave the introduction for, prevalence is just how common it is in the population. And so here we have different studies, and I think the 3.6 was actually one of Cormac's studies, that there's a high prevalence of Chiari in the population. And it's a common incidental finding, as he said as well. And one study had less than one-third of patients. And so going to the natural history, which he also talked about, a couple of quick questions. Can Chiari go away on its own without surgery? And in long-term data, is there long-term data, how it affects people across their lifespans? And if so, there'd be a point we can see it. This is a diagram he already showed you. And I think it shows that we can see over time that the tonsils tend to go up. And also, he alluded to this study as well, looking at the natural history, that for the most part, the tonsils don't change much, although there are some that can. Looking at flow studies, which is something that a lot of people talk about, the patients that had flow studies in this study, the highest proportion had no change. Some got better, some got worse. I think flow studies are very technically based, and I've had studies where they were done poorly, so then it looks like there's no flow. And so I tend to think that patients with poor flow, you're going to see that on an anatomical study. And so I'll use it, and it's part of our protocol for imaging, but I think it's more useful within a patient, comparing across time versus comparing across people. And I think it's one of those things that this is an area where I think people are trying to improve those studies, but I think as they are now, they're not necessarily that helpful. Here's a patient as an example of someone who could get better that I would say took care of, but didn't really do anything for him. 2006, as a very young toddler, had this MRI that showed a very significant Chiari malformation. They never saw anybody for it at this time. Had another chronic disease and saw a fellow in that specialty who noted the report of it, and so got another scan 7 years later, and then sent the patient to me, and you can see that it did get better. And so I think it is, my opinion also is, as Cormac had alluded to, is that you're more likely to see that in young patients because that's when the skull is growing, and you're more likely to see a change in that brain to skull anatomy. So can Chiari go away on its own without surgery? I think yes and no. I think there's definite differences between pediatrics and adults. So a patient who has a Chiari as a 1-year-old, I've seen a couple of patients who've actually, quote, grown out of their Chiari. And what does that mean? Maybe their skull base was flat when they started, and as they grew, it kind of came out, so there was more space. In adults, I think it's less likely. We saw that graph that the tonsil position goes up over time, but we're talking over many, many years. I think it's more likely that maybe symptoms may become less prevalent for certain people and not for others, but I don't think anatomically it's likely to go away based on natural history alone, and that goes there. In terms of long-term data, we really have kind of that study that we showed for tonsillar position over different people, but we don't really have long-term registries where we have like the Framingham Heart Study, where there is a patient who was diagnosed at the age of 20, and that patient was followed until they're 50. And I think that's I'll plug here for what Dorothy and the Bobby Jones group are trying to do, and what we're trying to do at Hopkins as well, is to collect data on patients specifically to be able to follow both the surgical and the non-surgical patients over time. So getting to presentation, I think obviously there's a lot of symptoms that people come in and complain about, and this is a lot of the questions that I got relate to symptoms. Cormac had showed one chart. Here's another one that you find online that's asking all kinds of questions about different symptoms. And I think this is a slide or things that people, this is an example similar that goes similar to an intro psych course or things like that. But the fact, this is ice cream sales and shark attacks. And the fact that they perfectly model each other on the time of the year, but sharks are attacking more people because of ice cream. It's because in summertime, you're more likely to eat ice cream and you're most likely to have a shark attack. And so the fact that they're happening together doesn't mean one is the cause of each other. And I think when we're thinking about Chiari and symptoms, that's a really important thing to think about. So the questions about symptoms: why does a good hard laugh hurt, and why does straining and pushing hurt so much? And I think that obviously is the classic symptom we talk about, and it really gets at, and to me, there's the explanation for that is the foramen magnum is the only, or should be the only kind of real hole in the skull. And if you think about it, straining, laughing hard, all of these things increase the pressure in our head. And the only outlet for that is the foramen magnum. So now you're not herniating every time you laugh or sneeze or your ICP goes up, but it potentially is microscopically putting pressure in that area. And so if you're already tight in that area, that's the way I tend to think about why straining would cause symptoms, because it's applying a force in the area where the things are tight. Can Chiari cause breathing problems and a cough? Yes. So we know that there is an incidence of sleep disordered breathing, and similarly cough with that. And I have a patient example a little bit later. Is constant fatigue a symptom of Chiari? And this was highlighted as asked many times. And I think this is where it can get a little bit harder with the correlation and causation. And also, can the direct causes of Chiari cause fatigue? So are you fatigued because you have a Chiari? Or are you fatigued because you have a Chiari and you have sleep disordered breathing and you're not sleeping well, and you have pain? And so I think it's hard to directly relate these things, but I think someone with a Chiari probably could have fatigue related to symptoms of Chiari. The last two I included just to say that these are things that I don't think are related to Chiari. Based on what we know about the brain, we tend not to think of grand mal seizures as coming from the posterior fossa. And then I have not personally seen hair loss, and I can't think of, unless you have headaches and are pulling at it, why a Chiari would directly cause hair loss. More questions kind of getting at the same things. Are at any point are there plans to reevaluate the class A Chiari symptom list? We keep being told that headache is the main concerns, but most of us have gotten to the point of ignoring them. There are other symptoms that are more concerning to us. And kind of getting back to things, the issue is that's the most reliable symptom. I'm going to talk about the guidelines in a second. Is that there are a lot of other things that have been attributed to Chiari. I joke with my patients that any symptom that any human has ever described at one point or another has been attributed to Chiari. Now, again, we get into that correlation and causation, but we know, and I actually try to duplicate in clinic strain-related headaches. And so we know that that's something that clearly relates. And so that's the easiest for us to predict as something that is going to improve with surgery versus the other things. I don't know that there is kind of necessarily an officially recognized list. I I use the example of tinnitus here. I have a number of patients who will come with tinnitus or ringing in their ears who don't know what that is. And it really is something that I've never used it as an indication for surgery. But in patients who I've treated who have tinnitus and a big Syrinx or strain-induced headaches or other reasons, it's all over the board. I've had patients where it didn't change at all. I had patients who it completely got better, and other patients who say it's a little bit more muted. And so it's one of those where the likelihood of it being related can be a little bit hard to tell for any specific instance. And I guess, the next question gets at that idea. Is it true that Chiari and MS mimic each other and often misdiagnose for the other? And I think both Chiari and MS, although not the original great imitator, which we won't get into, but they're both diagnoses that can cause a lot of symptoms that overlap with other diagnoses. And so it can be hard to figure out where they are and what's causing it. And obviously, Chiari and MS, there are specific criteria that would differentiate, especially MS. There's, the imaging should be different. There's CSF tests, there's eye tests that can be done. So they shouldn't really be misdiagnosed for each other, but I think somebody with symptoms, it could be a little confusing. And I had alluded to the guidelines and getting at that original, that first question on the last page about why do doctors care about headaches and not the other things, is exactly kind of what we found with writing the guidelines. And looking through all these different papers, the only thing that was consistent, was the strain-related headaches. Pretty much all the papers that looked at it, strain-related headaches got better. For other things, there might be one paper that says it got better and one paper that said it didn't. So when you're trying to synthesize that, it's hard to say something is if there's another paper that says it isn't. And so I think that's why people tend to focus on that. It's because it's the one that everybody can kind of agree on. This paper I'm not really going to get into kind of the nitty-gritty of, but I think it also shows an interesting point that I use to think about symptoms. And this was looking using the Park Reef's data to look at what happens with Syrinx size. But interestingly, one of the conclusions, when they looked at all the data, was that improvement in the Syrinx was also predictive of improvement in Chiari-related symptoms. Now that seemed like common sense, but why is that important? If you have someone who comes with 15 symptoms that have all been attributed to Chiari, and the Syrinx goes away, and 2 symptoms go away, but 13 don't, then treating the Chiari is probably not going to fix those 13 symptoms. This suggests that whatever was coming from the Chiari should get better with treating it if the Syrinx got better. And so I'll often tell my patients that I use, for patients that don't have a Syrinx, the strain-induced headache is really that predictor symptom of what, if that gets better, that's probably the indicator that we decompress the Chiari the way we need to. But if other things don't, maybe it could be related, but I think it's a lot less likely that it's from it. And so does that give the impetus to try other treatments or look for other things? Because again, going back to the fact that just because you have a headache and you have a Chiari, it doesn't mean that they're related. And I thought this was a very interesting paper from a couple of years ago. And it's astounding how common headaches are in the population if you look at this data. I take their word for it because I don't specialize in headache, but these numbers, 52% of people had an active headache disorder, and almost 5% had 15 or half of the month, half the days have a headache. Now, if you take Chiari prevalence at 0.24 to 3.6, and just to come up with numbers, I used 1.5%, kind of just splitting the difference. If you look at the world and say there's about 8.2 billion people, there are 64 million people, approximately, with a Chiari and a headache disorder. purely based on population statistics that they don't necessarily have to do with the other. And close to 5.7 million people with a Chiari and a headache more than half of the days of the month, purely based on population statistics. And so that's why it's important to try to get at, do we think the headaches are related or not? And it kind of, I put that in, getting at a lot of these questions, which kind of show frustration from coming from patients. You know, how can we manage the pain and symptoms of Chiari when doctors are saying you don't meet their criteria for decompression and no one will help? And I think it really is, it's a difficult question to answer, and I can't really speak for all the doctors out there. But in general, I think it's one of those things where more likely than not, it's not that they don't think the pain is real, but it's that trying to put it together, don't think the Chiari is necessarily the cause of the symptoms. And so if the symptoms aren't from the Chiari, then a neurosurgeon, you don't want them doing anything because it's not going to help you. Now, it was interesting, I was just at a meeting last week talking about other pain circuitry, and there was some discussion of neuromodulation and stimulators on other things, but it was kind of interesting to start thinking about, do some of these pain symptoms or other things, could they relate to altered neural pathways or circuitry that we don't really understand? And is this going to be one of the future forays into neuromodulation or things like that? For me, I think the biggest challenge in seeing patients with Chiari is really deciding who is the best person to operate on. And patient selection is really the key to success. If it's incidental and the symptoms aren't related, then you're going to give someone a scar on their neck and maybe some neck pain from the surgery, but you're not going to help them. You can't really make the symptoms better if they're not from the Chiari. You know, as one of the other papers that came out of Park Reeves looking at dural grafts showed with opening the dura, complication rate was about 30%. And so if you have a complication rate that's that high, do you really want to do something if you don't think it's going to make someone better? And everything as a surgeon is really weighing that risk-benefit ratio, and the benefits have to, outweigh the risks. Clearly, there's going to be some center and surgeon effects, and there's literature on that for all kinds of surgery, in the sense of high-volume centers, high-volume surgeons are probably going to have lower complication rates, and so maybe more likely to consider something and be as scared of complications. But at the same time, there has to be a benefit to do it. And I think really the highest likelihood of success is going to be, like Cormac kind of alluded to, talking about his surgical criteria, as patients with a classic headache and or like certain types of Syrinx. And so what's really the goal of treating patients with Chiari? It's the right operation for the right patient. And the third question of that is whether you should operate, because sometimes the quote, right operation is no operation. And so some of the questions related to this, what's the best way to decide when is the right time to seek surgical correction? And is Chiari malformation, treatment based only on symptoms and not herniation? And so the right time, I think, is the symptoms are related to Chiari. We don't have another etiology of the symptoms or of the Chiari, which I'll talk about shortly. And then the other thing is the impact on quality of life has to be enough to have surgery. If they have a symptomatic Chiari, but they get a symptom of it once every 6 months, it's probably not worth the surgery. Whereas if it's happening every day and it's limiting, the ability to carry out activities of daily living, then it definitely makes sense. And I think that's a personal decision for patients in terms of weighing the benefits against the risks. And in terms of, are you deciding based on symptoms, the answer in a lot of ways is yes. And I think it's important that, like a big Syrinx, most people would consider like a symptom, but we don't really recommend surgery for asymptomatic patients who don't have a Syrinx. And that was actually one of the other questions in the guidelines that the literature does support. So I had alluded to in the last slide, etiology of Chiari, and some of the questions came up about secondary Chiari. What are contributing illnesses or direct causes of secondary Chiari, and is there a way to tell? And it gets at, the point that I usually like to make is to treat the underlying etiology of the Chiari, not the Chiari if it's secondary. And so what are primary causes of a secondary Chiari? I mean, we tend to think about it as pressure. So you can have Chiari from hydrocephalus, intracranial hypertension, which can relate to obesity sometimes. But I saw one study that showed that obesity affected tonsil position. They didn't control for a pseudotumor, so I wonder whether that may have been the cause. And then brain mass. Patients with brain tumors often will have a Chiari, and you treat the brain tumor, and the Chiari will get better. The other thing is low intracranial pressure, so spinal fluid leaks, or patients with lumboperitoneal strokes. You can see the Chiaris kind of develop over time. And a couple of cases to kind of illustrate these. I had a young, healthy, active female who presented with headaches that were worse for about 6 months. She stopped doing deadlifts because they were worse with strain. She also could have a morning headache, and her PCP ordered imaging, and she had Chiari and mild ventriculomegaly shown here. When I looked at the scan, I was a little bit worried about the anatomy of the aqueduct. I sent her for another MRI, which we can see here, and an opto exam, and she had papilledema and effectively had aqueductal stenosis. So we treat the aqueductal stenosis, her intracranial pressure gets better, and you can see 3 months after a third ventriculostomy, there's more space at the foramen magnum and her symptoms are better. So she had a clearly symptomatic Chiari, but the problem wasn't the Chiari, it was the elevated pressure. And the idea is we needed to treat the pressure. Now on the opposite side is this patient who presented with classic symptoms. And this MRI scan, which shows obviously a tight foramen magnum. The other thing I noticed was this angle here and the flattening of the pons, so I was worried about low pressure. Fortunately, she'd had an MRI 4 years before for other reasons, and we could see that she didn't have a Chiari at that point. Now, this is not a pediatric patient, she's an adult, and so this shouldn't happen. And so that tells you that there's probably something else going on. And at contrast MRI, you see this diffuse leptomeningeal enhancement, which fits with a CSF leak. So I sent her to interventional radiology, and she got better, but then some symptoms came back, so they patched other areas, and it can be a little bit of a work in progress, but with blood patching, her Chiari got better and the leptomeningeal enhancement got better. So you're treating the source of the problem. She never got Chiari surgery, and the Chiari symptoms went away. And so how can you tell if it's from birth or secondary? Doctor stating all Chiaris are only from birth. So I tend to prefer the term developmental rather than congenital, and I think it is because I have seen patients who had MRIs as infants and didn't have a Chiari, but then when they were 4, did. And again, I think it's more likely in the youngest kids where the skull is growing and the brain is developing within that skull. So I tend to think it should happen during growth, and I think the slide Cormac showed with tonsils peaking at the lowest at 21 to 30, I think just reflects probably most of it happens during growth. Now, I think when I have a patient that I'm not sure about, someone presents in their 60s and they have new symptoms, to me that raises red flags about a secondary Chiari. And so you're going to look for signs of high pressure. So you can see things like an empty cella. You can see things like optic nerve edema or other things on an MRI scan. Or you can see things indicative of low pressure, like leptomeningeal enhancement, or, like I said, the angle at the brainstem, the flattening of the pons. So sometimes it's additional imaging. Sometimes it becomes one of those things that you're just not sure, and then it becomes the risk-benefit discussion of, do you treat the Chiari not knowing if you're missing something, Or do you do an ICP monitoring trial? With an ICP monitor is a diagnostic procedure without therapeutic benefit, but it might tell you what's going on. So I think that's kind of the discussion. So, right operation for the right patient. Sometimes it's no operation, but when it does come to surgery, what is the right operation? And so some patient questions about this. What's the difference between decompression surgery and phylum surgery for Chiari? And what's the best treatment for Chiari? And what are different reasoning criteria for different treatments? So for me, my opinion is that the gold standard for treatment of Chiari is decompression. And this is for primary Chiari, obviously not secondary, as we've talked about. And there can be ranges of how the decompression is done, whether it's a PFD, which is a bone-only decompression, PFDD, which is decompression with duroplasty, PFDRT is with reduction of the tonsils, so you're shrinking and resecting tonsils. And I think it's a continuum in terms of what any patient might need. But I think there's those ranges, but I think decompression is the surgery. There was a question that came up earlier in the chat about PVDO, which is distraction. And I think that is something that's making the skull bigger. I've seen this and agree with that for patients who have problem with the skull not being formed properly, so it doesn't grow, and that's what causes it. There are some people out there who do it for everybody, and honestly, I think that's a bigger surgery than a Chiari decompression. So again, kind of would treat it if it's the source of the problem. Other groups have proposed phylum sectioning and fusion as other possibilities. The theories behind it, phylum sectioning, they say it's traction on the spinal cord that causes the Chiari. I don't think that necessarily makes sense to me. Because the cerebellar tonsils and how they aren't really being pulled down by the spinal cord. But that's one of the theories. And then fusion, the thought is it's atlantoaxial instability that causes it. My personal opinion is that there's probably a subset of patients that has tethered cord or that has atlantoaxial instability, and those treatments are useful for those specific patients. But I don't think it's for a Chiari one, not of standard etiology, so to speak, that do these things. And so the literature on this was out of Italy. They looked at the papers that were out there, and even looked at experimental evidence that showed that, both in animal models and in other people with tethered cord, that isn't related to myelomeningocele, that those people didn't have Chiari. So it's hard to state that. Another paper out of Brazil that was looking at it for government use looked at two papers from one group and effectively said that it wasn't good literature. It's level 4 evidence at best, and so there was no scientific support for sectioning the file as a treatment for Chiari, and that there needs to be better literature to support that. I think, therefore, my practice is deciding the right operation, is thinking about whether I'm opening the dura, shrinking the tonsils for a Syrinx, am I placing a stent, for someone with instability, are we fusing? I think there's relative risk and benefits of all of these procedures, and the more you do, you're making more space, but there's potentially some additional risk. One question that came through, in what cases would tonsil removal be necessary? Every part of the brain is important, right? Even if we don't know what it does. And I think there are practice variations. There are a lot of surgeons who standardly resect tonsils. Personally, I'm more likely to cauterize than resect. But there are exceptions based on patients. Here's an example. A toddler I saw who had sleep apnea and a pretty significant Chiari malformation. We took him to the operating room for a decompression. Here's the ultrasound, and we can see there's not really any room here before we open the dura. So we open the dura, and immediately what we're looking at is just his right cerebellar tonsil is kind of filling the whole space, and we can't see the end of it. So we shrank the tonsils significantly. And you can see where the white is where kind of we shrank them, splitting between the tonsils, showing that there's a nice outflow of the fourth ventricle. One technical point, I tend not to cauterize like the medial aspect, because I've seen patients where these scar together if you cauterize there, so I tend to stay on the outside to prevent that. But at the end, now the tonsils are both fully up in the graft. I was pretty happy with myself. But he didn't get that. His cough got a little bit better. The scan definitely didn't look as good as I thought it was going to look. And his central apneas got worse. And so I felt like I had done as much as I could do with shrinking the tonsils. We went back in. There's a little bit more space here, but it doesn't look great. That being said, this is before I did anything, just opened the door, I actually thought this didn't look as bad. We could see the outflow, but the tonsils are moving a pretty good amount here and covering. So this was a case where I did resect some tonsils. And the way I do that is make a small hole and then do what's called a subpeel resection, where you work on the inside and internally do it, with the idea being you're trying to make less of a surface for scarring. And so there's a much bigger opening there now. The ultrasound shows a much bigger space. And despite that huge space, the post-op scan doesn't look as good as you think it would, but it looks good enough. His apneas are gone, he's off BiPAP, and doing very well now years later. And so I think there are times where to make enough space is just something that you need to do. Now, what about most and least common risks of decompression surgery? Honestly, again, getting back to what are you doing? Are you doing a bone only versus opening the dura? In general, I would say that it's well tolerated, and a lot of the people are very fearful of the surgery, and I would say for the most part, most people do well after it. But things that we see that you don't necessarily think about, positioning injuries. So a breathing tube in your mouth, your nose, and your face down, tongue or lip swelling. I have a couple of patients who complain more about tongue swelling after the surgery or lip swelling than the pain in the back of their head. You can get pressure sores. Somehow we hold you can get a cut or even a fracture. These things aren't common, but they're things that can happen. I would say that one of the most common things potentially could be, it doesn't fix the symptoms you want to. There's also the risk of what we call cerebellar ptosis, which is you do too big of a decompression. So I kind of say you want to aim for the Goldilocks decompression, which is you don't want too big or too small, because either way you can have problems from it. With opening the dura, I think chemical meningitis, which is typically treated with steroids, is one of the things we probably see more commonly. We also have case reports about patients who develop hydrocephalus after that we've reported treating medically and conservatively with things like Diamox and steroids as the body's adjusting to new spinal fluid dynamics. Long term, there's also, with opening dura, risk of intradural scarring if you're resecting tonsils or things. And so these are all things to think about. But in general, I think it tends to be a well-tolerated procedure. What does it mean when you have decompression, get better for a short time, and then get worse? I tend to think about this in two main ways. One, and I think I've seen this more with bone-only decompressions, is you did enough, it looked good, but there's scar, and you don't make as much space when you just do a bone-only decompression, and so you have less room to take back. And so I've had a few patients who, after a bone-only decompression, were 1 month, where like, I'm doing great. 3 months, start to have some symptoms come back, and you get a scan, and effectively scar tissue has taken over where the bone is. And so it doesn't look that much better than it did. The other, and it gets back to the correlation does not equal causation, it's possible that the symptoms weren't related to the Chiari. And it could have gotten better related to other factors related to the surgery. Meds from anesthesia or medications that you're on after the surgery, or even other interventions. I have one patient example I used that came to me as a second opinion because they had a shunt. And every time they had a shunt surgery, the headaches got better, but then they came back. And so we actually did an ICP monitor because it seemed to me that the shunt was working. The pressures were okay, and the headaches got better for a month. An ICP monitor is completely non-therapeutic, but he was better, and the patient was better for a month. So something about the surgery helped, but it may not have been the decompression. So those are the things that I tend to think about there. Does surgery really stop or slow the progression of symptoms? Yes, if the symptoms are from Chiari and is adequately decompressed. If the symptoms are from Chiari, it's not going to stop them. If the Chiari is not decompressed well enough, then it's not going to stop them. Is delaying decompression likely to result in increased damage? Then again, I think based on the other questions and my other answers, most of you can probably answer this. It really depends. If a patient is grossly symptomatic with significant compression or Syrinx, then there's potentially ongoing damage, and it may likely get worse the longer you wait. We often have patients who have big life events coming up, and they're like, can I wait to do the surgery? And usually you're like, well, you've been fine for 25 years. There's a good chance you'll be fine if you wait another month or two. But it's hard to say definitively. Whereas if you're asymptomatic, if imaging doesn't look that compressive, you don't have Syrinx, there's not really any damage going on. And I think this gets back to the discussion about sports and activity. And that was also, I tend to agree with what Cormac said, and that I tend to be fairly permissive. And that's something else that we did talk about in the guidelines. Generally, after decompression surgery, what's recommended time to wait to resume normal activities such as driving, exercise, etc. I think this is something where you shouldn't use what I say. If you're post-op from somebody else, you should listen to that person's practice. But my practice in general is that for driving, I tend not to be at 2 weeks or 1 month. I tend to have kind of general rules that people can follow. If you're not taking any sedating meds and you have good range of motion in your neck and you can turn quickly, like you need to drive, you can drive. For some people, that may be a week. For some people, it may be 3 months. It's really kind of looking at when is it safe. For exercise straining, I tend to think for bone only, I usually 4 to 6 weeks, just to let the sutures heal, wound healing. It's muscle, and so if you pull a lot, you can pull on things. With opening the dura, I tend to be a little bit more conservative and wait a little bit longer. So, you're not straining and pushing through. Now, obviously, I have exceptions. I have one patient who had a very physical job that needed to get back to it, and we actually got a scan a little bit earlier for him because he had a thing he had to do, and it looked okay. There was no pseudotumor, so we let him go back early. How does imaging monitoring of a Chiari patient work? What criteria are needed? And I think, again, there's going to be practice variation. I was in a Delphi looking at this for hydrocephalus. So it's going to be practice dependent, and everybody's a little bit different. My general practice is that asymptomatic or incidental Chiaris without a Syrinx. Pediatric patients, I often would like to see them, again, depending on how bad it is, through their growth period. Now, that may be 1 more scan, maybe 2 more scans, depending. Adults, potentially 1 year later or as needed, unless there were significant imaging findings. I have one patient who's completely incidental, but has tonsils to see too. So I've actually been following her because I think she's more likely to develop things. Questionably symptomatic, so the patient that comes that has symptoms, but it's not clear if it's from Chiari, or maybe a small Syrinx that isn't enough to treat, usually at least 6 to 12 months later, while trying other treatments, if it's headaches, they're seeing the headache specialist or working on other things to try to figure out, is it Chiari or not, and then can kind of see, and as long as it looks the same, then, determine it from there. Post-op with no Syrinx, I tend to do 3 months and a year. If they're young, then I may follow them as I would for an asymptomatic. Adults tend to be 1 year and then as needed. Some people call and have problems, so we get a scan, but if they're doing great, I don't think they need it. Syrinx, I think I will like the patients without Syrinx, but there can be long-term, you're more likely to have long-term recurrence of a Syrinx than a Chiari based on scarring and other things like that, so I tend to follow them a little bit more long-term. Other common questions is Chiari hereditary and their genetic markers. It can be isolated, but there are definite familial associations. In my practice, I've operated on mother and son, mother and daughter. I've operated on siblings. And actually I have one patient that I've just treated, the youngest, but mom and grandma both had Chiaris that were treated. So it is something that can run in families. And there are some active ongoing investigations, both at WashU and St. Louis and MGH, that you could just contact those places wherever you are, and they'll help you with a kit to do genetic testing. Getting at a question Cormac asked or talked about, pregnancy. Can pregnancy or delivery affect Chiari symptoms or even herniation size? And I think there are a couple of interesting things that Cormac brought up. The literature suggests that patients with Chiari can undergo labor safely. I actually have a phrase pre-done in Epic for kind of stating my feelings about it. My general finding is I think the anesthesiologists and the OBs are afraid. And so, you end up having more C-sections and changing the anesthesia because they're afraid of making things worse. And there's really two main considerations. Patients who are grossly symptomatic with strain. So, and I can think of one patient I had who knew she had a Chiari, knew she was symptomatic, but didn't really want to treat it until she thought about having kids. And then we talked about it, and she was not going to be able to go through that process. We decompressed her Chiari. She had kids the next year and has been doing great. But if you're grossly symptomatic with straining, you're probably not going to tolerate pushing the baby. So if you're really high risk like that, then it may be something that you would want to treat before. If you're not symptomatic and you can strain, then there really isn't evidence that you can't. And then the other thing, and I think the reason why people get pushed towards C-section and maybe not epidurals, is the risk of CSF leak related to anesthesia. Now, an epidural does not cause CSF leak, but if an epidural becomes a spinal, then there can be. And I think the recommendation, if that were to happen, is just patients should get a blood patch. But I think it is something that comes up, and it really, like he said, it comes down to the patient and their doctors and OB anesthesia having that discussion. And so finally, just wanted to get a little bit, I alluded to before, like the frustration. And there are a lot of questions that highlight frustration of patients is, why is there seemingly little to no knowledge in the medical community about the actual symptoms of Chiari? Why do neurologists and even neurosurgeons not have to know up-to-date information about an illness they see people for? And why do we have to live life as if nothing is wrong due to doctors not taking our diagnosis seriously? And I think what it kind of gets at is we do have a lot left to learn. There are a lot of things we don't know, and I think reviewing the literature and writing the guidelines shows us that there are a lot of things we don't know. But I think when we think about symptoms of Chiari, I think it really gets back to that correlation does not equal causation. Is that, just because somebody with a Chiari has a symptom, it doesn't mean that it's the cause. And that's what really gets at why it's hard to pin down for any one specific patient what's caused by Chiari and what isn't. And so I think sometimes that can come off as not knowing what you're talking about. And honestly, the only way to figure it out is through research and registries and following surgical patients and doing it in a systematic fashion to be able to look at it. And I said before the discussion of, quote, altered circuitry in patients with difficult to diagnose neurological symptoms Could there be something with that in Chiari patients that is not the Chiari, but there are other things causing the symptoms? And at the end of the day, to kind of figure these things out, you need data and you need funding to get that data, and patient participation is necessary. So how can you as a patient or a family member play a role? If you're a candidate, participate in research. It typically has to be done through clinical care, so you have to be a patient at a center that's involved in research. Obviously, I talked about genetic studies are the exception to that. You can contact those sites, and if you need it, I'm sure the Bobby Jones group can help with contacts for both WashU or MGH. And we have the CSSS study, which is a surgical study, and there are sites across the country that if you're having surgery, you can have your data collected. Bobby Jones is also trying to set up a registry, and I think there are other sites. I think Cormac's trying to do that at Stanford, and they're doing it at Alabama. We're doing it at Hopkins, trying to also collect non-surgical patients. And I think it's the way to try to, by collecting all of this data is really the only way that we can better answer the questions that people have. And obviously there's a limited population out there, but if you're able, obviously can help fund research as well. And I will stop there and open it up to questions.
Thanks so much, Eric. That was fantastic. Mary, were there any Zoom questions that we should get to?
We do have a couple. We can start in the room or start online?
Yeah, well, let's start. Any questions in the room? Okay, we're going to start online. All right. Where should we go? Okay. All right, so I'm just going to go down. We have 8 questions from the Zoom audience. Number 1, what's the difference between pseudotumor and Chiari? Eric, do you want to take this one?
Sure. So pseudotumor, or now I think people tend to refer to it more as idiopathic intracranial hypertension, is when you have elevated intracranial pressure. And so you can have symptoms related to the pressure itself, or you can get a Chiari from the elevated intracranial pressure. And so I think somebody who has IIH, the first thing you want to do is treat that. And there are groups who treat it. So I have an adult colleague at the CSF Disorder Center that kind of, with neurology and neurosurgery, sometimes it's medications like Diamox. There's a lot more evidence now that maybe it relates to venous problems. And so they're doing stenting of veins to treat it. Oftentimes it's found with people who just had significant weight gain. So things like GLP-1 agonists or bariatric surgery have been used, and with treatment of the pressure, those treatments, the pressure gets better, and then oftentimes we'll see Chiari get better. Now, I have had patients who had papilledema, which is swelling of the eyes, which is kind of the classic sign, who that got treated, and then they still had a Chiari or still had a Syrinx, and the symptoms stayed. So you may then still have to treat the Chiari. But usually you want to treat the primary source, which is the pressure first. I do have one case of a child who actually had pressure, and it sometimes can be a little bit of chicken and egg, but I think in general that's the way I would tend to think about it.
Yeah, I agree. I think it's really important to identify patients that have idiopathic intracranial hypertension, or what used to be called pseudotumor, preoperatively, because obviously they're at high risk for just getting a Chiari decompression for CSF leak and things like that. So you do need to treat the pressure first. If they still have a Chiari, then you would consider treating the Chiari, at least in my practice. We have quite a few questions on genetics with Chiari, and I'm going to try to sort of combine them if I can. Somebody says, is Chiari more genetic, hereditary, accidental aging, or other occurrence? Wondering if there's any genetic or research updates on the odds of inheriting Chiari, what do I tell my children the odds are of passing it down? This is obviously a really big topic, and there's a lot of really good people researching this. For me, I think that the simplest way I would understand this is Chiari is not a genetic disease in the way that doctors usually talk about genetic diseases, right? It's not cystic fibrosis. It's not one of these autosomal dominant things that we're going to pass on to half of our children or all of our children or that sort of thing. I think Chiari is inherited, like so many things in life, in a very complex, multi-genic way. We inherit Chiari, in my opinion, like we inherit our face shape. So when we walk into a family reunion and we see a relative that we never met before, we say, oh yeah, that must be Aunt Joan's family because they look exactly like Aunt Joan, right? And so Chiari, that's face shape. And back of the head shape is probably the same thing, and there's lots of different genetic components to that. However, I do not believe that for most patients suffering from Chiari that we're ever going to find a Chiari gene. Number of gene candidates have been identified, and then when you actually study it in the large Chiari population, it turns out, well, that's not so much true. It was just that like one family or a couple of families. I think 50 years from now, when we know everything about this topic, instead of being just at the very outset now of making educated guesses, I think what we'll find is that there are 100 Chiari genes or 500 Chiari genes, but there's certainly not going to be one or two Chiari genes. So this is not a genetic disease in the usual sense of what we mean by that word. And I think it's unlikely that we're going to get to the point in our lifetimes where understanding the genetics of Chiari better is going to lead to actual improvements in patient care. That's my probably controversial 2 cents. Eric, do you want to add anything?
I mean, I think there's definitely the hereditary component, obviously, and I think we talked about this a little bit in the guideline, and I would say if people are interested, the guidelines, you don't have to have a subscription; they are free, like from the Congress of Neurological Surgeons, and I think getting at this, the idea was, there's the question of screening. And I think that's a little bit what this question is. Maybe I'm inferring a little bit too much, but getting at is do family members need to be screened if someone has a Chiari? And the fact is it's not like an aneurysm where it's a fatal diagnosis, like if it bleeds, you can die from it. And so I think the general take is we don't treat asymptomatic Chiari. And so if someone in a family is normal and has other people have Chiari and have no symptoms whatsoever, then it's probably not worth looking at. Whereas if they have symptoms that may vary, then maybe you have a lower threshold, like in my mind, to get a scan, because we know it can run in families. But I agree, it's not necessarily something that we're going to find one specific gene that then we can come up with a directed therapy to put that gene back in, and Chiari is going to go away.
Thanks, Eric. Next question. If over time tonsils tend to go up, can adults with persistent Chiari headaches, even after decompression surgery, expect symptoms to improve as they age? I think that's an interesting question, and for me, it would depend on the time frame that the individual is talking about. As we both showed in our slides, tonsils do tend to go up over time. The trouble is they tend to go up over decades, and it's really no good at all for me to tell a patient, don't worry, you're going to feel fine in 30 years, right? That's no good. So yes, your tonsils will eventually go up, but you need to feel better sooner than that. So the question is, did you actually have successful surgery or not? If you still are symptomatic, it's probably not. And then you get into the question is like, are your headaches actually being caused by the Chiari? If they are, was your surgery done properly or not? And if not, it needs to be done properly. If your headaches were multifactorial or not entirely caused by the Chiari, well, that's where you need to get plugged into a different type of practitioner. Here we work with physical medicine doctors, pain doctors, and so on, and you need to consider getting injections and so on. There's another question from a different Zoom participant asking about the benefit of Botox injections into the cervical musculature. And for sure, that's an example of something that can be helpful for some people, right? There's not a one-size-fits-all approach, but for some people where that's the headache generator, that's something that they need to consider. The final thing I would say about this question, what to do about the fact that you still have headaches and you've already had Chiari surgery, is that the headache literature is actually pretty optimistic on this point. I think when people are right in the middle of it and they're experiencing daily headaches and they're not having the quality of life that they want to have, the neurology headache literature, not specific to the Chiari question, but just looking at headaches in general, again, can, I think, give you some hope. Because when you do long-term follow-up studies of people that are plugged in with a neurologist and trying to get better with their headaches, and you follow up with these people 5 or 10 years down the road and you ask them how their headaches are, in the majority of cases, the headaches are better. And that's not necessarily because they had more surgery, it's because they've been working with a neurologist or a more comprehensive pain program to get better. And that does work most of the time. Eric, do you have any thoughts about that question?
No, I mean, I kind of agree with what you said in the fact of, I think, and what I was getting at is, I think there was the question that I had brought up was, if it doesn't get better, or maybe you get better for a short time, it's either you're not decompressed well enough, or that symptom may not be related to the Chiari. And I think that's where kind of looking at the imaging, and also thinking about the symptoms and things like blocks, things like physical therapy. I think the hardest, when we talk about the strain-induced headaches, I think the one place I've been fooled for strain-induced headaches obviously isn't migraines, it's muscle tension. Because if you have a really tight neck, I'll usually ask my patients to Valsalva to see if I can generate a headache and feel like the patients that I can generate a headache are more likely to be symptomatic of Chiari. And I think the one thing that can fool that is tight neck muscles. So that's something else to think about. I do have to credit Jerry Oaks. He gave a talk and I stole that from him, but I found it very helpful in my practice.
Yeah, thanks, Eric. I also took that from Jerry Oaks and call it the Jerry Oaks rule. If you can give yourself a headache when you're in the office with me, you have a very high likelihood of getting better. That's sort of the classic strain-related headache. We have 2 questions about neurofibromatosis as it relates to Chiari. NF1 or 2, is it related to Chiari and Syringomyelia? Not as such. Dr. Jackson, I think, had a few really nice slides talking about secondary Chiari malformation, Chiari caused by things that are space occupying in the head. Syringomyelia can be caused by things that are space occupying in the spinal canal that change flow in the spinal canal. So certainly we see Syringomyelia in NF patients, and you can see a Chiari malformation in NF patients, but I personally would treat those patients from sort of the first principle, like what's actually causing the Chiari, what's actually causing the Syrinx, not so much what the result is, which is the Chiari and the Syrinx. All patients are different, of course, and I'm not exactly sure what this particular patient is going through with respect to the NF and the Chiari, but that would be my general take on how those 2 diseases interact. Dr. Jackson, any thoughts?
I would agree. Yeah, I agree. And I also think I've seen, I have a patient that I can think of in my practice who had Chiari and incidentally found big Syrinx because they had imaging for their MS. Mm-hmm. So also there's the fact of just, I think, when somebody has something, are they more likely to get a scan and maybe more likely to find something that's there.
Next question, does osteoporosis or malnutrition with poor tissue strength affect Chiari surgery success or contribute to cerebellar herniation? I personally don't believe that there's any data to show that it contributes to cerebellar herniation. I do think that being healthy in general is the best possible thing you can do if you're having any surgery, including Chiari surgery, and being in good physical shape is helpful. Having said that, that doesn't mean that you can't have Chiari surgery if you are suffering from any related condition, but it does increase the risk of a healing problem, especially.
Agreed.
Okay. I think we got through everything. There's a last question here, which I think is probably the most controversial, about upright MRI versus regular MRIs in your practice. I personally don't use upright MRI regularly. All of the data we have on Chiari is with regular MRI. That's where all of the statistics that we showed you about people getting better or not getting better is based on. So it's a little bit, it's an interpretive problem about upright MRI. And furthermore, we tend to not see very great differences between the two. So I've never made it a regular part of my practice. I think that's controversial. Some people do, but again, I'm still waiting for evidence to show that it's helpful. Dr. Jackson?
There was one other question I saw. I kind of talked about upright a little bit. I personally haven't seen huge differences. I do have patients. There's a bunch of upright MRIs near where I am, so patients will come to me with them. And I often, the other thing about them is upright MRIs are always open MRIs, so sometimes the quality of the imaging may not be as good. I also think for flexion extension imaging, like our institution, you can get them supine, and some people argue, oh, well, that's not truly representative. And I haven't seen someone who had supine flexion extension imaging that didn't show instability that then went on to have an upright MRI and showed something. And there's a lot of measurements and things on those studies that we don't even really know what they mean. So, I mean, I think it's one of those areas where obviously it's a new thing, and if somebody can kind of present literature that it makes a difference, and there are things that I think that's a lot of the things that we talk about in Chiari, where there's groups that are doing things differently. The problem I have is a lot of those groups don't publish good data. And so I think it really is something where when we to change practice, we need data. And I think if there's somebody who thinks there's something that really works, then show us and kind of publish it. Would be my general public service announcement in that regard.
Thanks. I think that was very well put and very diplomatically put. So one more question, and I think we'll call it at that point. We have a couple of questions about Chiari 1.5, the meaning of it and how often we see it. And Dr. Jackson had and then there's one, we'll get to your question. Dr. Jackson had, I think, a couple of slides about Chiari 1.5. Just to add my 2 cents, it's very definitional, right? It's a relatively newer definition that we've come up with for 1.5. We used to just call them bad Chiari 1s. And for me, I still treat them more or less like bad Chiari 1s. You do a Chiari decompression, which for me is never a bone only. I always open the dura, do a duroplasty, do a tonsillectomy. And I treat Chiari 1s like that, and I treat Chiari 1.5s like that. Chiari 1.5, technically you're seeing a caudal descent of some of the brainstem as well. But honestly, it doesn't change the way I'm going to treat the patient in terms of what the surgical recommendation is going to be. If they're going to get surgery, it's because they have a certain set of symptoms and MRI findings. And the 1.5 versus 1 is actually not a very material change in how I'm going to recommend surgery or not. The one thing that it does change is we know that patients with Chiari 1.5 with the caudal descent to the brainstem have a slightly less good outcome. So I do introduce that in my counseling for patients when we're talking about if they want to have surgery or not have surgery. I always have to come up with a best guess for what somebody's outcome is going to be. Do they have a 95% chance of symptom relief or a 75% chance of symptom relief or somewhere in between there. And the Chiari 1.5 is a little bit of a knock against them when it comes to me making a prediction for symptom relief.
I would agree with that. I think also Chiari 1.5s often are associated, and this is just maybe the ones I see, with more skull-base abnormalities, flattened clivus, and kind of the angles at the skull base, which we also know does put people at a higher risk of potentially needing a fusion. I can say in my practice, I don't think there's a patient I've, at least in my Chiari practice, ever done an upfront fusion for. But, you know, I have seen patients and who've ultimately ended up requiring it. And you know, oftentimes those skull base anatomy abnormalities with vascular imagination, other things will also kind of go along with and the anatomic changes of Chiari 1.5 or just generally complex Chiari.
All right, and with that, I think we're going to call it for today's session. I would like to thank Dr. Eric Jackson from Johns Hopkins for participating and for that really insightful talk with answering so many questions. I want to thank Bobby Jones, CSF, for flying all the way from New York to be with us today. And I think this series of lectures is going to be available on the Bobby Jones CSF website. So I think one of the earlier questions that Eric had is, you know, what are the resources that are out there that we can trust? And the Bobby Jones Chiari Syringomyelia Foundation website is really, I think, the best information out there on this disease and its treatment. And they've got how many videos online now?
Almost, I think 700.
Yeah, so 700 Chiari videos, all available for free online for Chiari patients. So I would really encourage anybody who hasn't been to that website to visit that. So thank you, Dorothy and Mary and Julia for making the trip. And then most importantly, I want to thank all of our Chiari patients and their supporters for being with us tonight. We really appreciate it, including all of you out there on Zoom. Thank you so much for making tonight happen. Okay.